Good morning, good afternoon to everyone, and welcome to today's webinar. My name is Archer Rogers. I am the manager of West Coast Partnerships here at Healthweave, and I'll be moderating our conversation today. I'm really looking forward to hearing from our panelists who are in the trenches today using social care to advance health equity for historically underinvested communities. Before we kick off the discussion, I just want to go back over some of the house rules. Next slide, please. So the Q&A function is located on the bottom right-hand side of the screen, and if you experience any technical issues, please private message the event producer. Throughout the presentation, please feel free to send all questions and feedback through the Q&A function. We will answer what we can get to at the end. We will also be sharing a poll at the end, so please make sure to fill that out as well. We really would appreciate your feedback. And finally, this webinar is being recorded and will be shared out afterwards to all who registered and attended, and will also be posted on the Healthweave website. Next slide. For those of you who are new to Healthweave, we are an organization that runs both local and national projects, typically focused on the integration of social care into clinical care delivery. The ultimate aim of these projects is to unearth and address the roots of racial inequity that will impact our health today. Therefore, aligning with our mission and values, we believe that it is our responsibility to partner with others to share learning and create spaces of inquiry created and centered on equity in healthcare, especially when it comes to integrating social care into clinical care delivery. We believe that conversation is needed even more now than ever. Even in the COVID-19 era, we see evidence of how systemic oppression is affecting so many. Next slide, please. So sadly, during the COVID-19 era, we're seeing, hearing, and even feeling the familiar patterns of racial and economic bias in response to the pandemic. For example, similar to many historical public health narratives, we're seeing the same narrative of an attribution of a disease on a minority group. This is sadly leading to explicit and implicit bias and discrimination targeting members of the Asian Pacific Islander community. Secondly, states and cities who have begun to show a racial breakdown of COVID-19 deaths by race already have revealed that Black communities are disproportionately impacted as having the highest percentage of deaths in some states, yet despite being a smaller percentage of the population within their community. I even recently read this morning that some reporting is showing that the Latino communities are also estimated to suffer disproportionately as well. Also, community members who are in our safety net are having a harder time connecting to the resources they need to be healthy. And lastly, even in the aftermath of COVID-19, when the shelter-in-place orders are lifted, it is believed that historically underinvested communities will be hit the most due to unemployment and loss of business. Next slide. Ultimately today, we are here to do three things. Hear from experts on how they intentionally integrate an equity-oriented framework into the way they have implemented social need interventions, particularly in regards to screening and navigation or connection to resources. Secondly, we believe that social needs interventions have to step into the role more explicitly of addressing inequities and even perpetuated discrimination, especially if our work will touch the lives of many who come from historically underinvested communities. Lastly, we want to create a space of dialogue for you to discuss how we as a community, as a professional community, can elevate and create practices focused on intentionally integrating equity and social need interventions. Now more than ever, the focus should be on bringing forth narratives that speak to what is needed for the healthcare system to not only benefit everyone from every community, but also what is needed for that system to thrive. As we're learning through this crisis that we're all connected and interdependent on each other. And for that, I'm really excited to have these 4 panelists joining us today. Next slide, please. We have Leticia Reyes-Nash, the Director of the Office of Programmatic Services and Innovation at Cook County Health. At Cook County Health, Ms. Reyes-Nash also serves as the co-lead for the Center of Health Equity and Innovation. Her current projects focus on addressing social determinants of health, specifically housing, behavioral health, advocacy rooted in justice, and food security. Next, we have Moraya, who is the Director of Programs for the Los Angeles County Department of Health Services, Women's Health Programs and Innovations. In her role, Moini leads a variety of women's health initiatives, including Mama's Neighborhood, which is a multidisciplinary, mother-centered program that begins at pregnancy and supports the mother, baby, and family up to 18 months postpartum. Mama's Neighborhood has been replicated throughout LA County and is also integrated in the criminal justice system. We'll actually begin our webinar with a presentation from 2 speakers. First, we have Namisha Patel, the Associate Vice President of Management Services at Duke Health Private Diagnostic Clinic, PLLC. In her role, she leads and directs programs and initiatives to enhance the patient and provider experience across Duke's collection of outpatient services. And we have Taiji Hill, the National Director of Partnerships and Innovations here at Healthweave. In her role at Healthweave, she uses her extensive experience in implementation management and program evaluation to assist institutions in assessing, designing, and implementing social needs interventions. I do want to say that COVID-19 has affected us all in many different ways, and many individuals are working from home with their children, and that goes for some of our panelists as well. So we're asking everyone to please be gracious if you hear any background noise while the panelists are speaking. So with most social need interventions, there's a focus on connecting individuals to resources. However, Namisha and Taiji will teach us the importance of integrating an equity orientation within the first aspect of a social needs intervention, which is simply how we ask people about social needs or social risk. We often call this step screening. Now I'll turn it over to Namisha and Taiji to give our first presentation.
Cool. Thanks, Arter. We could go ahead and go to the next slide. And the next slide. We'd like to start by outlining some of the key reasons of why including community voice is a necessary approach when developing a social needs program. When we think about health more holistically and not limited to the care provided within a clinical setting, the key drivers of health are social and environmental. That's not debatable anymore, and this relationship is increasingly becoming an on-the-ground reality for our providers and healthcare system leaders as we approach value-based care. A world where knowing a population's social profile will not be an option, but required. Sustained access to things like food, housing, transportation, education are major influencers of health outcomes of a population, more so than the clinical care, which only makes up a small picture of a person's overall health. The relative importance of addressing these factors shift from context to context, place to place. And so it's people who are living in that place that are best suited to define what health means to them and as a result, determine what the key priorities are. Residents in a community should have control over the decision-making process that affects their health. This leads to a more equitable design. Put more simply, it's the difference between creating for someone based on a set of assumptions versus designing with someone based on their direct input and lived experiences. Taiji will share more details about this. Connecting with community stakeholders and residents to co-create something is a chance to seed trust by demonstrating credibility and genuinely caring. A conversation around essential needs in the clinical setting requires us to ask our patients and families to be vulnerable and disclose their personal day-to-day challenges. So trust is a critical component for those conversations to happen in a dignified way during the screening portion of a clinical visit. With a program built on the foundation of listening to a community and incorporating their point of view into the way we operationalize these programs works. This effectiveness comes through in the program's adoption and utilization. It seems simple enough to make a commitment to co-create, but current cultural norms will resist this type of radical collaboration, and it requires equity and human-centered champions to push and facilitate this mental shift. Now I'll turn it over to Taiji. Taiji will share with us elements of the screening process that are so important to design with the community. We can move on to the next slide.
Thank you, Namisha. Here are areas where we have found engaging the community in the screening design to be particularly helpful. Oftentimes, we believe we know the needs that exist in communities from our exploration of available data and experiences working with families or individuals from the community. But we have found by engaging the community, we get a deeper understanding of what the actual needs are, which leads to a more informed intervention. Patients and community members often know the resource landscape better than we do, both formal and informal resources. They are incredibly resourceful, and I believe this is a significant contributor to their resilience. They can also explain the ease or challenges of navigating various resources. For example, we worked with a partner that was developing a program for a pediatric and women's clinic, and they expected that food would be the greatest need, and later realized that food was easily navigated and clothing and furniture were actually the greatest needs due to limited resources in the community. All of this information combined will help your teams collectively determine a scope that will prove most helpful to the community and therefore increase engagement. It's important to consider every step of the screening process because if we are not careful, we can make patients and community members feel unsafe and less willing to be vulnerable and disclose their social needs. It's important to ask permission and state the purpose and timing of the conversation up front. Patients or clients should know they do not have to participate in the process until they feel comfortable doing so. We have also found that the framing of the questions can influence how patients and clients engage in screening. For example, in a California community, we found that screening questions with the word need, for example, I need help finding employment or job training, made the Latinx males in that community feel emasculated and resulted in them either not acknowledging their social needs or not using the provided resources. When we framed the intake as a conversation instead and noted that these resources are available to them, they were more willing to engage. Finally, for the presentation of questions, it's important to make every effort to ensure the questions are understood and create space for follow-up questions. Try to have the questions written in at least a 5th grade reading level because literacy may be a challenge experienced by some. Use the patient's preferred language. Some patients are bi or multilingual, and it's important not to make assumptions about their preferred language. Instead, ask and make the questions and resources available in that language. Be thoughtful about who asks the question. There is much evidence that demonstrates the benefit of having a workforce that resembles your patient or community population. They may be better equipped to speak the same language. We have found that native speakers are often preferred over those who have been formally trained to speak the language. Because of their lived experience and unique understanding of the communities they serve, Community health workers are well positioned for screening because patients are often more comfortable discussing the barriers they face in accessing resources with someone who they believe can relate to their experiences. Many of the notes I just shared are lessons we have learned after hours of screening, many confused patients, frustrated staff, and data that did not demonstrate adoption. Over time, we recognize the power of engaging the community from the beginning and throughout the life of the program, including spin-off programs. It results in programs that progress more quickly and have higher adoption rates. Next slide, please. Now we're going to explore ways to ensure patients and community members can comfortably engage with the question. It's key that all staff involved in screening are thoroughly trained. We have seen programs where the patients or community members have disengaged at the very beginning because the person who handed them the screener was unpleasant or unclear in how they explained the questions and process. Or it could be the person who reviews the screening questions with the patient in a way that makes them feel uncomfortable or disrespected by their tone, body language, no eye contact, or not considering the environment. This resulted in patients being less willing to engage in the process or follow up on provided resources. We recommend the following trainings for creating a safe space where the patient or community members will be willing to be more vulnerable with your team. Cultural humility requires team members to develop a deeper understanding of each individual, particularly their strengths. I like how Robert Wood Johnson Foundation framed it. It requires the team members to step outside of themselves and be open to other people's identities in a way that acknowledges their authority over their own experiences. In understanding the communities we work with, it's critical to understand the historical context of current happenings. Many of these historical experiences are responsible for the systemic barriers experienced today and the strained relationships that exist between some institutions and communities. These are all important steps to understanding one's bias and relinquishing power and moving towards shared decision-making with the community. Implicit bias training is also important so that team members become aware of their implicit bias and have tools for combating patterns of thinking that are rooted in bias. This is important because if we're not careful, we will have interactions and policies that are rooted in unconscious bias and result in unintentional harm. A trauma-informed team is better equipped to recognize the impact of the various types of trauma experienced by individuals and provide support and understanding. If we are not careful, our processes and approaches can re-traumatize trauma survivors. It's important to take a universal approach to trauma in order to build a compassionate relationship with the communities we partner with. Empathic inquiry is a conversational approach to social needs screening and was developed by the Oregon Primary Care Association to promote partnership, affirmation, and patient engagement through social needs screening. It combines both motivational interviewing and trauma-informed care with the goal of fostering collaboration and emotional support for both patients and staff through the social needs screening process. This also highlights patient social needs priorities so that it can be integrated into follow-up care, planning, and delivery. Screening is a critical element of a social needs program, the engine. It drives other elements of the program like navigation, outcomes, and our data-driven decision-making like staff and community partnerships. For our social needs programs to move us closer to health equity, we must start with an equitable process that involves the community. Next slide, please. Now Namisha is going to talk about how and at what level to engage community input.
While this table might imply otherwise, right off the bat, I want to point out that setting up for community collaboration isn't clear-cut. And it's typically more of a fluid approach and ends up being some hybrid of the characteristics seen here. To determine what works best for you and your organization, it's helpful to be clear on how much power and decision-making the leaders are willing to relinquish, and to be informed about what types of dynamics are present in the community. So what I want to do here is zoom into level 3 because I think most of us have experienced some version of level 1 and even heard about some version of level 2. Level 3 really flips level 1 on its head, and this is where things get really good in terms of community co-creation. The representation here is a blend of community stakeholders from the health organizations as well as cross-sector organizations like education, housing, food, transportation, and the community residents who have taken the initiative to be change agents and are part of a community action network, coalition, or neighborhood group. The decision-making is community-led, and the organization that traditionally holds the power and relative privilege are now accountable to the community. In the past, we've done this through building a memorandum of understanding with the community, where the community outlines what the organizations are accountable for. Community members' expertise is formalized and acknowledged at this level. They are compensated with a living minimum wage, at least. In this level, there are peer researchers who are asking the questions and having the conversations with residents about their barriers. And this setup leads to richer data and reveals and unpacks the disconnects between what people need to live healthier lives and the service experiences that are available. I believe making an investment in becoming a community-led organization drives systems of care that breathe strong engagement and relationships between patients and providers. Organizations that build the muscle to value relationships, share power, and appreciate different sources of information will be the ones that outperform the status quo. Next slide. Here's one powerful example of how our own thinking was dramatically shifted when working with community. When I was at Healthweave, a team of us connected with Black women in Boston around addressing the health disparities. All of us know all too well the differences in maternal and infant mortality across racial lines. So we wanted to get to the root of this by conducting community-led focus groups. Check out the way one of our focus group questions evolved as we gained deeper guidance from residents in Boston on how to frame the question. Before their input, the box in red, the question had no mention of racism as an issue. That's the first version. In the second version of the question, the box in yellow, we're getting closer after one round of feedback from a patient advisory council. But racism is still phrased as a possibility rather than a known barrier. After more community guidance from individuals with real lived experiences, we landed on version 3 and the actual question we used. Racism is now phrased as a known barrier and appears in the first 3 words of the question. In this version, we get to a point where we confront the core issue. Here's why this matters. If we stopped at version 1, then that is just looking at the differences by race, which is the status quo. We don't get to the heart of the matter. We can't really create meaningful interventions if we stop there. So now, I hope you can imagine, even a little bit, what is possible and solvable when we retool the current ways of working and deciding. And with that, I'll hand it back over to Arter.
Thank you so much, Namisha and Taiji. You really have called us to think through cultural humility and how that will be integrated in the screening process. And this last example of showing how community itself can be helpful in designing questions was really a big takeaway for me. A lot of times when we talk about social need interventions, we're going beyond screening to talk about the connection to resources. And research continues to show us the difficulty of ensuring that patients actually receive the resources and the services that they are screened for and referred to. So Leticia is going to really focus in on the resource connection piece. Leticia is going to challenge us to think through our approach to navigation, since many social need interventions target members of historically underinvested communities. So Leticia, with that, I'll turn it over to you to provide us with the second presentation of today's webinar. Next slide, please. Next slide.
Great. Thank you so much, Artair. It's a pleasure to be amongst so many great experts and leaders in this area. Next slide, please. So just to give you a quick background on Cook County Health. So Cook County Health is the public health provider in Cook County, and that Cook County encompasses 5.2 million people, which includes the city of Chicago, which is 2.7 million people. Amongst the suburbs, we have 128 municipalities within the county of Cook. So it's a wide, vast community that is very diverse. And our Cook County Health has a Medicaid managed care plan. We are a healthcare provider with 15 clinics, 2 hospitals, a specialized center that addresses HIV, as well as we serve as the provider in the Cook County Jail. We also do provide the provision of the public health provision for suburban Cook County. Next slide. And all of the description of the health system is really to just tell you the breadth and scope of the reach of the health system. We're a $2.8 billion organization, so we have a lot of opportunity to engage with our patients and to have opportunities to make change. And so this past year, we have created the Center for Health Equity and Innovation, which brings together a data analytics unit called the Collaborative Research Unit, and the Ideation and Funding Unit, which is the unit that I oversee. And we have really made a decision as a health system to make health equity a strategic priority. And we, looking at this IHI model, we think this is really a great way to think about what's necessary as an organization to think about what's needed in order to achieve health equity. So making it a strategic priority is one step. But the next step is to then develop the structure and processes to support health equity work. So that's operationalizing the business of health equity and making it part of your regular operational flow. And that was addressed in the conversation that we just had around screening. So we have universal screening across our health system for all patients around social determinants of health. So that's one step. We have other trainings and other things around health equity that's institutionalized as part of our core business and what we do. We also are looking at specific strategies and work on implementing specific strategies to address the different social needs that are emerged amongst our patients. We have acknowledged that we need to decrease institutional racism within the organization, acknowledge racism as a barrier for many of our patients to accessing health within their communities and across the system, but also understanding that these are system players that are promulgating a lot of the different challenges that our patients have to face, and we have to think about not only individual interventions, but we also have to think about how we're addressing those system problems that are continuing to be a barrier for our patients to have healthy lives. And then partnerships. A core piece of everything that we do is to foster and develop partnerships with community organizations, other partners, other governmental partners, to work to improve health equity. Without that partnership piece, we really would not be able to do this work at all. It's a key element. Next slide, please. So, we work on a lot of different topics within the health system. I failed to mention that our health system serves 83% of the homeless population in Chicago. We serve 37% of the homeless population in the suburbs. And we serve everybody regardless of their ability to pay. We've been around for 180 years. Our business overall is to ensure everyone has access to care. And so with us, we are at the forefront to making sure that social needs are addressed for our patients, because our patients are the most vulnerable in Cook County. So these are current activities that we have in place. We have lots of activities, but I will talk about just talking about the necessity of having layered approaches not simply stopping at screening and individual intervention. I think that we all acknowledge we have patients right now who need individual interventions and we need to address their needs, but we can't stop at doing that. We have to contemplate the other layers of intervention that are necessary for us to be able to have long-standing success working with our patients. And so the one example we have here around the opioid epidemic, we are working individually. We've expanded medication-assisted access across our 15 health clinics. We have recovery coaches that are working to successfully manage individuals with MAT access who leave the jail and go into the community. And we've seen that individuals who move to MAT who are in the jail and individuals who are referred from the community do just as well. And really, we credit a lot of that success to our recovery coaches who work behind the wall. And then when those individuals leave, they also consult and work with those patients to help them connect to care in the community. So, you know, working on that individual intervention, but another piece is we also have to work on the institutional components and inequity. So, for example, we work with the adult probation population in Cook County, which is about 16,000 individuals who are at any given time on probation in Cook County. And the policies within that did not support recovery principles, so our clinicians provide consultation around the policies in adult probation to have policies in place that are more supportive of recovery for individuals who are seeking help, and so or to look to link individuals to support. So we had to really grapple with that policy piece in order for us to be successful as we were doing individual screenings and linkages for individuals in adult probation who needed service provision. And then overall, working at the social inequity level, advocating for a minimum wage ordinance, reducing stigma around MAT. That is, you know, medication-assisted treatment. That's a big issue overall. And overall, looking at decarceration of individuals and working hard to link individuals with services in the community so that we reduce the number of people who are in the jail at all. Also working on the front end with the Chicago Police Department to reduce arrests for low-level possession and other kind of issues that we can, again, engage individuals prior to engagement at the jail. So we have other interventions around engaging with the Chicago Police Department with our triage centers, linking individuals, again, to service provision rather than the justice system. So we have a number of projects there. And so similarly with the food insecurity work, we have layered approaches as well, where we're working to have individual education. We have linkages to our fresh trucks and our partnership with the Greater Food Depository, working with our own purchasing practices as a county and how do we ensure that we're purchasing good food. And then also looking at working on opposing SNAP changes and making sure that people have accessibility to SNAP. So again, this is really about having this layered approach around interventions so that we can have a long-standing impact. Next slide. So what does this mean for the COVID response? So really in this moment where we have this need to move quickly and take action, I want to mention a couple of important things. So in the city of Chicago right now, 72% of the COVID-19 deaths in Chicago are African American. In addition, we have, and as you know, you may or may not know, the population in Chicago for African Americans is 29%. So what we're seeing right now is all of the underinvestment, all of the, you know, what we have worked on all the time, and we talk about addressing health equity. We have this flashpoint of a moment where the data is becoming really evident that individuals who have more chronic health conditions, who don't have access to housing, who don't have the resources they need to be able to shelter in place effectively, we're seeing the spread of the COVID-19 impacting the African American community disproportionately. The city of Chicago is working and having a rapid response team. I will say the number one thing in your community as you're doing this work is to really ensure that there's data being collected around COVID-19. The city of Chicago has made an effort to redouble their efforts to ensure that demographic data, race and ethnicity data is collected during this time so we really understand the magnitude of this problem. And then immediately we work on taking actions to help to resolve and to provide the resources needed to remediate this disparity. And so I will just say that, I know my time is running out here, I will just say that I think that that is a really critical piece, and then looking at other things that we need to do to ensure that these disparities are acknowledged and that we're able to take action now, but also to learn from what is happening now so that we can make the investments we need to ensure that we have the social infrastructure to support the communities that we serve. And so we are working hard at the health system in partnership with the City of Chicago and all of the other governmental partners to ensure that our patients get what they need. But because we've done the hard work of having these community partnerships and these relationships, we're able to go quickly to these partners and work on flexible strategies to address the needs of our community. Next slide. So what do we need to do post-COVID-19? Well, we know that we're behind and we have had these disparities. I don't think anybody is surprised to see these disparities rise up during COVID-19. But I think that as I talk about my work all the time, I think health equity is a business imperative. It is critical that health systems, partners, that we build in equity strategies as part of our core business. And I think that after COVID-19, that won't be a debate any longer. It'll be a requirement and it'll be a necessity as we go forward post-COVID-19. We need a comprehensive approach to address the resource landscape. The reason why I struggle when I talk about just individual interventions in different populations is because there's intersectionality amongst all of them. And so we have to really understand what that intersectionality is and how we need to approach that, and understand that it's not an issue that is super clear, but we have to be able to understand how all of these systems intersect. And I often like to say to people that, when we look at systems fail people, people don't fail in systems. And so it's really critical to understand that we have to figure out what are these system failures and how do we fix those system failures so people can be more successful and better served. And then we need alignment. We really need to look across all of our partners and systems and continue to work to align our work and understand the intersectionality we all have in order to successfully serve the communities that we serve. Next slide. I think that's it. Thank you.
Thank you so much, Leticia. You really challenged us to really think about the investment we're making within our infrastructure, but you also really taught us to think of beyond just individual resources, to think about the policies that affect people as well. I love the framing that you had of getting us into the root cause, which includes social inequities, institutional inequities, living conditions, and risk behaviors. All the things that you have said, Leticia, and even things that Taiji and Amisha have mentioned, allows us to understand that there's a context and place where people live that we have to consider. And it's really important for social needs interventions to be used to address discrimination and perceptions of discrimination perpetuated by the healthcare system and the systems that patients interact with. So Moraya, our final speaker, will talk about how her program coupled clinical and social care together to address a specific health disparity present within many communities, including Los Angeles County. I'll now turn it over to Moraya. Next slide, please.
Good morning, everyone. Thank you, our chair and health leads, for inviting me to this really wonderful presentation and the opportunity to speak with many individuals and be a part of such a great topic. I am the Director of Programs and Operations at the Los Angeles County Department of Health Services for Women's Health Programs and Innovations, and specifically have been a part of the design and implementation team for Mama's Neighborhood, for which I'll talk to you about today. Next slide. I'd like to start out by saying that structural oppression has its place in how we see preterm birth presenting itself in Los Angeles County. Specifically, I'd like to draw your attention to the left-hand part of the screen where you will see Los Angeles County itself. We are one of 27 counties in California. We span about 4,000 plus square miles, and we have the largest population of any county in the nation. We have about 30% of California's population for the state. We have over 10 million residents. And specifically, I'd like to just share with you that we have about 1 million African American Black residents, half of those pretty much an even split between male and female. And of the females, about half of them are in reproductive age range, and a good number, about 25 to 30,000, are under 5. The population for African Americans on the whole for Los Angeles is about 10% of our population. And specifically, if you look at the left-hand part of your screen again and see SPA 1, or what we call Service Planning Area 1, at the very top, that is called the Antelope Valley. And just the Antelope Valley alone is half of our county. It is very large, it is very spread out, and 20% of its population is African American. I mentioned the African American and Black population in specific because we have the largest disparities seen in infant mortality, maternal mortality, and preterm birth in that specific population, very similar to other parts of the county and the nation itself. If you look at the right-hand part of your screen, again, Mama's Neighborhood, which I will describe in just a few moments, spans the whole county. We have 3 birthing hospitals, and we have almost 19 to 20 ambulatory care clinics that include women's health services. Preterm birth in Los Angeles County is very much of concern. Why? Because the Antelope Valley is alone at 11% of that population has preterm birth. And this is actually almost twice the amount that we're seeing in the rest of the population of their white counterparts. That's in infant mortality is twice, excuse me, let me rephrase that, I'm sorry. Infant mortality is 2 times the amount in the Antelope Valley, and in SPA 6, or Service Planning Area 6, maternal mortality is seen as 3 to 4 times that of their white counterparts. Next slide. Preterm birth separated out by race and ethnicity. You will see here that African Americans are at 12, almost 13%, and Native Americans are at 16%. So when we look at populations and their percentages, it's important to frame this in terms of the total population, but also when we're sharing this information with our communities, that we provide some context to this. And so the title of this slide is really important, where we see how structural oppression ends up looking and it within race ethnicity, for example. It's important for us to be able to see how the systems that we set up trickle around and down to the actual race and ethnicity and different populations in terms of their culture. Next slide. In California versus Los Angeles County, and then DHS deliveries and SPA 6 and SPA 8, you will see that the distribution of percent of preterm birth and low birth weight are specifically more egregious in the DHS deliveries. Why is that? We see the highest risk populations and those that have the most complicated comorbidities. Many times, other hospitals or health systems are not capable and have no capacity to be able to see the highest risk populations. For example, in Mama's Neighborhood, we will often see an individual with diabetes, hypertension, cancer, and some sort of cardiovascular disease all at once. And then on top of that, maybe also experiencing other structurally oppressive systemic barriers that have placed them at more risk for preterm birth. This is particularly important to note because within working with the Department of Health Services, it is our job implicitly to be able to remove these barriers that are structurally oppressive and have been designed, frankly, for, as long as we can, go back decades for the middle class. We look at health insurance, we look at the way programs are designed, and when we see that individuals are considered last in the way that we design programs rather than first. Next slide. So a little bit about mother-centered care models and Mama's Neighborhood. This program was designed and catapulted out of the Center for Medicaid and Medicare Services, specifically their innovations branch under the Strong Start Initiative back in 2012, 2013. It was very much focused on leveling the playing field and lifting up the voices and positions of patients or mothers to improve birth outcomes so that we could set mom up for a better interpregnancy interval or interconception care, for motherhood itself, and then to reduce infant and maternal mortality and make sure that baby is meeting her or his milestones. Mother-centered care is very much a part of how we have structured the program to combat structural oppression. If you look at how systems have been created, again, throughout different counties in the United States, many times there are individuals and leaders in place that are position themselves very much separately from the end user, which is the patient. So Mama's Neighborhood addressed this by putting the mother at the very center, her family, the neighborhood, and then the health systems last. And that is very intentional because we honor and acknowledge the fact that moms spend the most of their time with their families, in their communities, and we are really at only 5 to 10% of the time that she spends. So MAMAS actually is an acronym that stands for Maternity, Assessment, Management, Access, and Service Synergy throughout the neighborhood for health. Next slide. What we had to do at Mama's Neighborhood in our program is to make sure that we addressed health equity head on, and we made the necessary shifts in our paradigm of care in a very intentional way. We went from more of a traditional episodic, prescriptive deficit model, and one that was referring people to community services and not following them all the way to linkage, and one that was very individually and focused and self-centered. We moved over to one that was honoring the life course of a mom, shared decision-making, leveling that playing field, looking at social determinants as more contributors rather than determining the end point of where they will be, which kind of implies doom and gloom for individuals, especially when we're trying to build a new common language amongst providers, health leaders, and policymakers and shapers. Using the word determinants is also language that is structurally oppressive. We leverage their protective factors and not always looking at what they don't have, but more looking at what they do have because they're coping, they're getting by, not in maybe the best way, but there are things that they have put in place. And it is our job within the provider sector and health systems at any level to find out what those strengths are in our population because they exist. We leveled ourselves in terms of cultural humility as well. Rather than being competent in something, we wanted to be humble. We came to the table asking permission. We came to the table making sure that we took a back seat to how mom wanted to drive her health care. Rather than assuming that we knew everything, we came in feeling that blank slate, we know nothing at this point. We want to find out what it is that you would like to focus on. We will highlight for you what is important in pregnancy and in postpartum, and we will share with you that knowledge. But then we will take a back seat and ask you, how would you like to move forward in your care? We made sure that we were not at the center of care. We made sure that we had linked connections to services and a neighborhood focus, in that we were creating neighborhood networks of care. So going to, for example, the county council or the legal department for the whole county and figuring out, for example, an MOU or a memorandum of understanding that got over the structural barrier of HIPAA, we made sure that we could share information of limited nature with organizations so that we could actually link our mothers in a productive, substantive way. Next slide. So I'll quickly go through these last bits where we talk about our outcomes. I just wanted to show you here that by asking permission to have the conversation, much as the previous presenters have really eloquently shared with you, it's really important how you phrase those questions and how you come in very, I like to say, heart-centered. And I say that because not to be soft and, you know, we're all policymakers and we're all providers, but more so to intentionally come to the table to show that you care. Empathic care is critical to improving birth outcomes or health outcomes in general, and that is very much noted in the literature. Mama's Neighborhood spent an enormous amount of time identifying what all of these social care needs are. And you can see here that many things such as breastfeeding assistance, prenatal classes, which for us should focus on resiliency in an evidence-based way, utilizing WIC and other food services, was very important to moms, including mental health. This slide is meant to show you that by asking social care needs and asking it intentionally in a way that puts the mom in front of her own needs, gently, and I say that very intentionally, again, gently, because she knows the issues that she has. It's whether she wants to discuss them with you. And it's our job to make sure that we deserve that information and that we follow up appropriately, because structurally oppressed societies so many times delete having to get back and follow up with individuals. And this specifically in the African American or Black population happens and is noted very much in the literature, that the system does not follow up and does not care and has so much fragmentation and doesn't do its job to maintain them on the pathway to care. Next slide. Last here, I will say that we have seen majority of our patients deliver at term. We have a lot of work to do. We are not the best at everything. And again, I say that humbly because we have so much to do in terms of meeting our most disparate populations. But we have a lot, most of our moms are delivering at normal weight. Most of our moms are delivering at term. And in a system that it sees the most comorbid individuals and the most diversity, we're quite proud of the impact that we're making. Next slide. So on the forefront, at this point, we are focused on strengthening our trauma-informed care model. We will be investing more into public-private partnerships and building that network of care in a more substantive way. We will make sure that we're investing in community liaisons that are basically almost like pharmaceutical detail, but we're not for profit. And we're doing this for humanitarian purposes. You need people on the ground, not just outreach workers, quote unquote, but individuals who are skilled in maintaining partnerships between social care organizations and the health system. If you're going to truly make sure that there is a round table of care, you've got to make sure that you invest in the actual people who are making those relationships, period. The last thing that I will mention, but very importantly, is that we are starting to measure racism. We're using the experience of discrimination scale, which actually has been shown in many different pieces of research to be helpful in measuring racism and calling out those different race ethnicities and their experience of racism in the health system that they're seeing and how that affects their birth outcomes. There is one particular article that I'll draw you to at Northwestern by Dr. James Collins, who has shown that the experience of racism has actually contributed to lower birth weight and more preterm birth. I believe that's the end. Our chair, do I have one more? I think that's the end of my presentation.
Yeah.
Okay, I want to thank you all. Thank you so much, our chair.
Yeah, thank you so much, Moraya. You really did such a wonderful job showing how the integration of social care and clinical care can be linked to tackle disparities and being intentional on tackling the disparity. You showed that doing this work does cause for us to change the way we do business. I loved how you mentioned a paradigm shift in how you delivered care. And I think that that was something that was a theme that resonated throughout every presentation. So I wanted to thank Moraya and our other panelists, Namisha, Taiji, and Leticia. We truly appreciate all the wisdom you bestowed upon us today. It was great. I think that we all can leave knowing that we cannot be passive in integrating equity into social care. And I know that we have run out of time for an extensive Q&A, but we will get back to all of the questions that you have posed in the Q&A. If you have any last-minute questions, please feel free to put them in the Q&A chat. We will be sending out this webinar, the presentation and the slides, as well as responding to the questions in the chat. Again, we apologize for not being able to do an extensive Q&A. We do, if you have time, we would love to get your feedback on this webinar. I believe there's a polling question or a couple of polling questions that are on your screen at the moment. If you have time, please fill that out. Also, if you're interested in attending more learning opportunities, join us on April 17th at 12 p.m. Eastern Time, 9 a.m. Pacific Time for the first Healthweave Forum on how social needs programs are shifting during the pandemic to meet significant increases in demand for essential resources. This 60-minute facilitated discussion will allow attendees to share and discuss strategies for supporting frontline workers and marginalized communities during this stressful time. Also, stay tuned for more information on the next webinar in our three-part series, and you can email network@healthleadsusa.org for any further questions and to check out more resources. Thank you all so much for joining us today, and I would like to thank the panelists again for participating and giving us such great information during the webinar today. Thank you so much. Have a great day.